Hello. So I am back with a few new guests. So welcome to the panel here on reflecting on the past, the present, and the future of digital mental health. I am here with, I will do it in the order that I see on my screen here, Jonah Meyerhoff, who is an assistant professor with us at the Center for Behavioral Intervention Technologies at Northwestern University. So Jonah, his area is suicide prevention, and he works on developing digital tools that can support suicide prevention, and has been working in the last few years in how to safely integrate LLMs into those tools. Emily Lattie. Oh, I should also say that this is not only are these all esteemed individuals, but I should a disclosure here, they are also all either former mentees and current colleagues. So this is a special, uh, has sort of a special meaning for me personally. So Emily was an assistant professor with us at the center at Northwestern until a few years ago when she left to become director of clinical product at Lyra Health. She's a clinical psychologist and is also president of the International Society for Research on Internet Interventions. And Stephen Schueller, last but not least, you should all know because he is president of the Society for Digital Mental Health. He is also, in his spare time, a professor of psychology and informatics at the University of California at Irvine, and his research is on the design and development and implementation of digital mental health tools. And his implementation work is really in very diverse settings. In diverse populations, including safety net primary care clinics, county behavioral health services, and in youth experiencing homeless. So it's a real pleasure to have you all here. So just one bit of being adherent to the rules here. We have to disclose any conflicts of interest. So as I mentioned before, I do some consulting with Benchmark Health and OpenAI. So Jonah, Emily,
I have nothing to disclose.
nothing,
I am employed by and have equity in Lyra Health.
and Stephen.
I'm on the scientific advisory board for Headspace, and I've received consulting payments from Otsuka Pharmaceuticals and from Boehringer Ingelheim.
Great, thank you. And now, with that out of the way, we can get started with the discussion. And for folks here on the listening, please, if you have questions for the panel, go ahead and put them in the Q&A, and I will get to as many of those. We will get to as many of those as we can at the end of this. So we're going to be talking here for around 35 or 40 minutes and try to leave 10 minutes or so for questions. So starting with the past, looking back, looking back, what were some of do you feel are some of the core assumptions, as this field got going? What were some of the core assumptions that shaped digital mental health early on in the field, and which of those assumptions have held up over time, and which have not?
I think I want to talk right away. Can I do that, David?
I, Go ahead, get started.
All right. I think one of the huge assumptions early in the field was that if we build things, people are going to come and use them and then keep using them and use them as long as we intended them to be used and then get better. And we have learned over the last 30 years or so, and then particularly in the last like 15, as the pace of innovation and data collection has increased, that building things does not make people use them necessarily if we're just building for like one user particularly.
Yeah, I might bounce off of that and say I think that there's also this assumption that the secret sauce is the sort of clinical expertise and the intervention. And I think that we've learned that it's not just the clinical intervention. You need an effective thing, So I'm not trying to downplay our years of science and evidence-based practice, but the human experience is such an important piece of that as well. And it makes me think of a recent study that a trainee of mine and also a trainee of David's, Benji Cavaladze, did, where they did this mega study of different sort of single session interventions, and the one that was the most effective was based on an evidence-based practice, cognitive restructuring, but had gone through years of sort of refinement of the user experience. And so I think this field really brings together a lot of different expertise, and this society is a representation of that. But you can't just have an effective evidence-based practice. You really have to build it in a way that uses the affordances of technologies. And I think we've all been learning a lot in this field over the past couple decades. Clinical psychologists have been learning more how to design things. Designers in industry have been learning more about like what are effective clinical interventions. We've all been learning how to work together, and I think that that's really just broken that assumption that the clinical intervention itself is going to carry the benefit.
Yeah, I'll just say I totally agree with that. And I'll just I have I want to build off of that point, and I want to add one more assumption that I think has maybe partially held up. But I think on that point that the clinical intervention is the thing that we need to be focused on. We see this even in-person therapy where the clinical intervention is delivered via a person. And that person has a relationship with their patient or their client, and that relationship helps to deliver that intervention effectively. And I think that this kind of social nature of the thing that gets delivered, or rather the delivery tool, is so important to in-person therapy, and it can't be separated in the same way. You can't just have anybody deliver a particular intervention. They have to deliver it in ways that are acceptable and appropriate and make sense to somebody else. And this is true, I think, in digital mental health too. It doesn't have to be social in nature, but it does have to be delivered through this medium that is appropriate and effective for people. And then I'll just raise one other assumption that I think the field has partially held up, and that is that we have to target exactly the right people at exactly the right moment. And I think sometimes this is a really attractive idea. There's a lot of work that goes into just-in-time adaptive interventions, and those are really useful. And there's a lot of work that goes into personal sensing, and that it can also be really useful. But I think it doesn't always have to be not everything needs to be delivered exactly at the right moment, exactly at the right time to exactly the right person. I think there are ways we can deliver broad interventions that are preventive in nature, that are public health interventions in nature, and that help set the stage for other interventions and help set the stage for people to use the things that they need when they need it in ways that aren't perfectly targeted all of the time. And I see this a lot in the suicide prevention world, where people are really working hard, and for good reason, to target exactly the people who will need a particular suicide prevention intervention before they need it. And this is, I think, an important area of inquiry, but it also, I think, can miss the fact that we can deliver effective interventions like safety planning or other kinds of social connection interventions that are more upstream and that can set the stage for people to leverage some of these more effective interventions when they need it and how they need it. So I'll just throw that one out there.
Actually make just one more quick point on that, because like I do think this is an assumption that like I feel like I have made incorrectly previously, but I think when we talk about just in time as our field, I think we talk a lot about the exact moment. And like David and I did a lot of work when I was working with him around sort of passive sensing and trying to understand, can we predict that exact moment when someone is the most depressed? And I think we have to sort of broaden our thinking about just in time to not just be like the moment, but also maybe it's the week, maybe it's the month, maybe it's the year. And there's a lot of transitions that I think if we took a broader sort of aspect in terms of just in time and what that means, having a kid, job loss or starting a job, transition to college, like I think those are actually things that are easier to detect in some of the sensors we might have and actually might be more impactful. So I'd love to see sort of a shift in that sort of thinking of just in time to not just mean the minute, but also mean like the period in which a person is open for these things. And I think that breaking that assumption would actually be really useful for the field.
One thing that I wanted to piggyback onto, I completely agree with Stephen's points about these transitions that I think are easier to detect that are really meaningful for intervention. But something that Jonah was saying earlier about some of the human delivered aspects of intervention was making me think about another assumption that I think we've had as a field in digital mental health and in mental health treatment broadly about people are going to seek treatment, they're going to seek tools because they want to feel better. And people I think generally do want to feel better. And a misaligned thing that I've often seen over the last several years is that programs are designed to sometimes make people feel less bad rather than to make them feel better. And this piggybacks into what Stephen was talking about of really honing in on appropriate design principles so that we're creating interventions that are both evidence-based and engaging so that people want to use them because they match their goal of doing something, putting an effort. And like, it's hard to put in effort when we're not feeling good so that we're actually getting those steps towards feeling better and being kind of rewarded and prompted with those better things along the way rather than just less bad.
Yeah, I mean, so this is great. I mean, I think you guys have identified a number of different areas. I mean, one is the fact that it's not just about what we're telling them, but how we tell them, the importance of working across disciplines. So all of us here are psychologists, and I know all of us have worked with people in, from human computer interaction and human-centered design. We need to work with, again, sort of the big tent idea. This is no individual discipline can manage this, and then a lot of what you're talking about is implementation. So I want to move on then to currently, if you had to give the field a grade, not the science part, but really how are we doing in the real world? If you had to give the field a grade, what grade would you assign it and why?
I might go with like a B minus. I mean, I think there's some places we're doing really well. Like in California, for example, we have universal digital mental health for young people 0 through 25. That is amazing.
Mhm.
And that was not the case when I started in this field. I think we have a lot more knowledge about some of the effectiveness of these interventions. We have some demonstration of useful implementations. I will say in terms of like why is this not an A? I was really struck listening to your keynote, David, that a lot of the things you kind of mentioned as the current state of the field are exactly the same as the current state of the field we talked about, 7 years ago when we were at Banbury. We knew that these things worked. We knew we had some indication of some benefits in terms of, deployments. So, what's different? And so I still think we have a long ways to go. So I think we have some strong demonstrations, and I think the field is a lot further along now than it used to be. But I still think we have a long ways to go to really actualize on the potential of these types of tools.
I'm going to intervene just for a second to challenge you a little bit and maybe get Emily or other people to challenge it because I'm not sure we are exactly where we were 7 years ago. We are seeing implementations. The reimbursement thing hasn't been solved, the regulatory thing hasn't been solved, but we have made some progress, and I'm just going to use that to set up Emily a little bit.
Thank you. I agree that we have made
But I
progress.
want a grade, Emily.
Yes.
Come
All
on.
right. So I was gonna say I am against grade inflation and I am going to give the field based on my expectations, which are high and supportive. I'm giving the field a C plus right now. And I think we've made a ton of progress in the last 7 years since y'all were at Banbury, since the last, 15 years since I've been more engaged in it, there's been progress. There have been implementations, there have been changes to policy, but I don't think that we're as far along as we could be, given a huge amount of barriers. I give it the plus instead of just like we're at an average point right now because there are so many people coming together now from diverse disciplines. Like I'm so enheartened by the crowd that's at Society of Digital Mental Health and that I see engaging in other professional organizations and on professional networking sites. I think there's a lot of movement forward. I think there's been huge unlocks in both technology and in public recognition of the value of mental health from prevention to treatment. And I think we could be doing a lot better. So I'm going to go with a C plus and see if Jonah wants to challenge that.
I actually, when I was thinking about this question, I had initially said a B minus. So I feel like we're in the same ballpark. You know, but I think, on the one hand, and maybe I'll balance everybody. On the one hand, I see some of the core issues as still the core issues. Implementation still is a big problem. And on the other hand, the thing that I think we have seen over the last, I don't know, decade is there is a tremendous interest, both commercially and in research dollars, in digital mental health work. And I think there is a lot of societal movement trying to address some core problems from the design end, from the commercialization end, and really focusing in on mental health in a way that wasn't the case previously. And I think that matters a lot. I think the more we as a society across different sectors can start to focus on some of the core issues in addressing common mental health issues, more specialized mental health related problems. This creates real progress and competition, and that is really healthy, I think, for our field. And I think that's a real improvement over the last decade.
So, each of you kind of are touching on on the implementation challenges, and each of you is in kind of a different area. You all work in some healthcare, in community health settings, and deploying to employers. Where do you see really the biggest challenges and let's take the reimbursement thing off the page because we know that, but where are the biggest challenges in implementation from the vantage point of where you're working?
So I'm thinking specifically about the US context, and I think
Yeah.
a big challenge that I see is trying to figure out like what is it we implement and how do we actually get some information about like what are the sort of reasonable tools to consider. And I think that in my sort of experience at some of the different settings that I've been looking at, a lot of this happens through very sort of informal, connections or informal processes. Like somebody knows somebody who recommends a product, and then that's the one we're going to try. And that there's just a real hard, it's really hard also to make like apples to apples comparisons between different products. And I hear this from schools that I work with. I hear this from counties that I work with. People really want guidance or information about like, well, how does this tool work, and why should I use this tool? And I think that it's really challenging. And I think then a lot of these settings get stuck into sort of what I refer to, and others have used this term as well, as like pilotitis. It's like, okay, well, let's try this out. And there's often not really clear metrics, and then they try it, and there's some bumps, and there's maybe some successes, but then it just kind of goes on the shelf. And so I think really having some good standardized information of like what's out there and what's good and how do I get it to work is really, really challenging. Otherwise, I think we just go through these cycles of piloting without even, without ever moving it forward.
Can can I just respond to that? quickly because I agree. I think that is a real challenge. And at the same time, I think one of the big issues is um, when we have something that we know works, some principles that we know works, it is really tough to translate that into a variety of different communities with different needs. And I think it's really tricky to figure out, all right, what is the one or two or three best interventions that we can deliver for a community? And uh, I think there is some value to figuring out how to take core principles and adapt them so that, you are evaluating the same intervention effectively, but that adaptation process is necessary because it's true that not one intervention can't fit everybody. And that becomes really tricky when we're talking about scaling digital mental health. And so I agree that this is a really tricky problem, the fracturing and the different kind of heterogeneous needs of different communities. But at the same time, I do think there is some level of it that is required in order for people to get what they need out of a particular digital intervention.
Yeah, I appreciate that point. David, when you first asked that question, I was thinking about settings that I'm currently more involved in and settings that I've either been involved in the past or still talk with people quite a bit about. And I think one of the big challenges kind of across settings that I have heard about and have experienced in implementation is getting aligned with all of the relevant parties on what the value is and like where that value is going to be demonstrated. And so I think about this in terms of implementations in existing healthcare settings where having to take some amount of provider time or changes to a clinical workflow or getting kind of space, those all have costs associated with them and trying to get aligned on why it's worth the cost to do that. When we're thinking about the employer, selling to employer space, getting aligned on what value is going to be offered both in the short term and in the longer term to a company is it's been done in a lot of successful cases, but it's like getting aligned on that value and like what it's going to take. And when we think about direct to consumer kind of implementations too, thinking about myself as a user, like what amount of effort am I willing to expend, and where at what points am I going to recognize a value? And so I think that like getting aligned and communicating on value is often one of the most challenging things across different types of implementation settings.
All right. Well, thank you. This is really helpful. I think yeah, it sounds like what I'm hearing is kind of broadly what we really need is more guidance on implementation because there's just and it's not just sort of generally do X, but really detailed like you're talking about, Stephen, how do you select a product? How do you what are the specific, not just what are the specific procedures, but how you do them because these organizations don't have that expertise. And then what you're saying, Emily, I think gets missed at least. I think you being from a company have more of that perspective. Of being able to understand value and aligning the value with the different stakeholders so that people are on board and in the process. Those are really important points. I'm going to move now to kind of the future of digital mental health, and we can't really talk about the future without talking about AI. Um, so there, when I was thinking about this, I was thinking, we've had a lot of innovation, right, from the very beginning with digital mental health, where we were putting PowerPoints on the internet, and then creating some interactivity, and then moving that over to phones, and there was some ability to access sensor data and so on. But some of that might be viewed today as incremental changes, and I'm wondering, do with the advent of AI, is AI, do you feel like AI is really a fundamental transformative technology, or is it just simply kind of the latest technology cycle for digital mental health and why.
I'll talk and then let Jonah and Stephen disagree with me, or maybe even prompt David to chime in. Um, I had two immediate reactions to the question because AI is such a broad category. And I feel like I've been in so many spaces lately where people are equating AI with chatbot delivered solutions, and artificial intelligence, I think, is revolutionizing healthcare and mental health care and training and continued supervision and like workflows in really big ways right now too. And so if I were asked just about Gen AI chatbots, is that fundamentally different than the other forms of technology that we've used to push out mental health tools before? I would say I don't think it's fundamentally different. I think it's there are it, it's a different technology. There are other kind of risks and benefits and consequences and advantages that are afforded there, but I don't see it as being a completely different than how we had websites and how we've had like pre-programmed messaging programs before. But I do think that there's something really interesting and exciting about ways that artificial intelligence can be used for workforce development and for training purposes in ways that we've never been able to scale appropriately before and have, I think, suffered in some ways because of. And so I see kind of both sides of the coin there, and I see people coming off mute, so I want to hear what y'all have to say.
Well, I
I'm,
I
oh,
can
Stephen, go ahead.
disagree a little bit in that
Perfect.
I mean I do think AI and chatbots even specifically is transformational. I think it's going to change a lot of things. We just don't know how yet. And anyone who's been around me, and we use this word a lot in this field, potential, knows I hate the word potential because that means there's something we could be doing, but we're not doing it. So
Yeah.
potential is not good. Actualized potential is what we want. We want to have impact. Um, so a couple ways in which I think it really is different, and I think it really is kind of shifting things. One is, especially for psychologists, we've done a lot of the work in the past in digital mental health has required us to do a lot of interface design. We're really bad at this.
Mhm.
Whereas we have, 100 years of practice with the talking cure. And so I think actually changing to this modality that allows us to be focused a little bit more on language, I think actually helps. I'm being biased as a psychologist, but I think it helps us get more involved in that process. We know a lot about talking to people. We know a lot about language. I think that the types of interventions that we are used to doing in this field, I think, meet this sort of area really well. So I think that that's one aspect where I think it really is different. Um, I think going to a point you made earlier, Emily, around, like if we build it, they don't come and like these things sit on the shelves. People are using these. And I'm
Yeah.
not saying this is
No,
good.
they are.
Please,
And
please
I
do not
wasn't
use
saying that
ChatGPT
it
as your
not being
therapist.
fully transformational means that it's not an incredible step forward and that
Yeah,
it's not
yeah.
coming with like way different usage patterns than we've seen. But I think each of the technologies that David brought up too have come with different usage patterns over time. And so
Yeah, but I still
I
think
see
just
a
from like
lot
a
here.
public consumer point of view, like more people are using these generative AI platforms for mental health purposes, in my sort of read of it, than probably all previous apps put together.
Yeah.
So I think we just have like a huge just sort of shift. Now, again, I'm not saying this is a good thing. I think that there's a lot we sort of need to learn about that, but I do think we need to be listening and looking to like consumer behavior. Like, why are people using this, and what does that mean? I think another sort of piece going to David's point, some of his points earlier in his presentation, I think we have a huge, and I'm going to use this word, the word I said I hate, potential to measure quality, because we're tracking so much information of the interactions and the goes and back and forth that we actually probably could do some better job of tracking quality and measurement based care and those types of things. but we have to design this all thoughtfully. And this is not an emergent property of this technology. It's not just like, well, we have chatbots now, and now we're going to transform the system and it's all going to be great. Like, if you don't intentionally design these things, we will end up with a system that is worse than the system we have right now. So I think there's again, the word I hate, a huge potential for transformation. And I think we've seen some indications of moving in that direction, but I still think we have a ways to go, or we might end up with a D minus in the next 5 years rather than the C pluses and B minuses we currently gave the field.
Yeah, I just want to agree on I want to echo both of these points because I think the generative AI piece opens up this opportunity and sort of the the way people are using it is a one model for everything kind of approach. And this is good and bad. I think on the good end, it really increases accessibility and companies thinking about mental health care and safety because people are already using it for this purpose. And that is a step change in the adoption and implementation of these kinds of strategies and tools. I think about it from a technology standpoint a little bit more like Emily as sort of a delivery mechanism that is like the smartphone. It is transformative for sure, but it's a delivery mechanism. Now, I think there are ways that we as designers can really harness this technology to use it for really powerful purposes, and how companies can start to leverage those the things that are developed by intentionally designed experts in mental health, digital mental health work, to deliver those things because there's interest in them. The thing that I think a lot about, and we've seen this in our research, is that people really care that the interventions we build and develop are designed by people. That matters a lot to the folks that we talk to anyway. And so the fact that even though there is a huge demand for self-guided tools, the fact that an intervention was built by and designed by, even if not every message or tool or piece of it was built by a human, the fact that it was designed by a human has relational weight. And similar to the kind of social delivery of in-person interventions, I think that that matters a lot for credibility and for how people think about a digital mental health tool. So the relational piece of the fact that, this wasn't just created by a computer or spun up based on like the internet's worth of data, but a person actually thought about how do we put these two things together? How do we put these three components together? And can we use the LLM tools to stitch it together in a way that is thoughtful matters a lot. So I think there's a risk to us leveraging a cool technology for a cool technology's sake, but I really think there is an opportunity to capitalize on the societal interest and commercial interest in mental health related concerns. And I think we need to think about our humanity and what it is that we can actually infuse into this tool.
Okay, those are great, thoughtful questions, and it just strikes me that a lot of the themes in there are kind of about what we're doing, what we need to do with people, doesn't change. The principles of psychological change don't matter, but how we're interacting with them does matter, and what their sort of, their understanding of the source of that, as Jonah is mentioning, is important. I want to leave time for questions, but I want to get to one last, so I'm going to ask you to be a little bit brief, but a lot of our membership are students, people involved in education. So I want to take a moment here to get your thoughts on how a lot of our professional programs are still stuck in the same sort of training programs as training that we've used for the last 100 years, and the field is changing rapidly. What should we be doing to better prepare people in their training for this field, and what any advice you would have for students in the audience today?
I mean, I'll say I think interdisciplinarity is key. Really encourage my students to be taking classes in other departments and working with people in other disciplines. I do a lot of collaboration, as a faculty at UCI I live in a department of psychology, but I work a lot with people in Department of Informatics, School of Nursing, School of Medicine, School of Education. Um, so like I think really understanding how you work with people in different in different areas, because I do think it requires a lot of sort of interdisciplinarity. I just want to make another sort of shout out to that. I think that society has done a really great job with also helping train students for the different pathways they're interested in through the industry matching program that internship program we've done in collaboration with the Thriving Youth in the Digital Environment at UVA program. And I think that's just been such an excellent sort of opportunity. I think we can't stay in our sort of traditional lanes. I think we really have to think about how we get out there and get experiences from lots of different places.
I second the interdisciplinary nature of training. I think we've seen over the, rapid increase in technological innovation in the last handful of years too, that some of the things that are really core for training in work in mental health technology or digital mental health is having a really strong background in ethics, in communication, and in critical thinking, and want to, really encourage and I'm doing what I can to support the continued focus on those kind of more deep thinking and working together types of models of education, rather than the, pure accumulation of knowledge that we can sometimes get outside of the formal training settings too. But I think we need to be continuing to train folks across disciplines in how to be working together as there are incredible changes ahead too.
Yeah, I love these points, and I'll add a minor one, and that is that I think one of the things we can do is think about the theories that are unique to our fields and disciplines, and think about how do we start translating them across domains so that we can, to this interdisciplinary work, so that we can start to collaborate and integrate theory-driven work into the digital mental health technologies and the actual delivery tools, and start to build and test these things in ways that are really novel and exciting, that we haven't seen before.
Great. Well, thank you. We do have a lot to do to try to improve the development of the next generation of leaders in this field. I want to go now to questions. We have a lot of different questions, and I apologize to people in advance that we won't be able to get to all of them. I saw some questions in there around reimbursement, and I just want to make a clarification here. When we were talking about reimbursement, I think what we were talking about really are the structures for payment through insurance or through payer systems or through Medicare, not necessarily self pay. So I apologize for not being clearer on that. So one of the, there's a number of questions here around how to, what your thoughts are on what we need to do to better serve underserved communities. And then as sort of an adjunct to that, also questions around, a lot of what we've been talking about is kind of in healthcare or healthcare adjacent through employers. Are there, is part of that, where we're deploying? So how do we better serve underserved people who really we go into this because that's what we're trying to do, right? Not necessarily give more tools to people who can already afford and have psychotherapy and care available.
Yeah, I think, oh, sorry, Stephen, go ahead.
You go first.
I think one of the ways we start to do this is by listening and partnering with community partners to help develop, evaluate, and deploy tools that work well for those communities. And I think the thing that I keep coming back to is like, these things need to be, at least in part, even if not custom built, adapted in ways that are community specific, and the things that matter for one community may differ, even if like 90% of the kind of demographic variables are the same. The needs of different communities are different, and we have to, I think, incorporate those. And honestly, I think the LLM components of this that makes this a feasible problem. I think we can start to think about how do we leverage technologies to help us more quickly translate and adapt tools across to different communities and to different needs. But we have to work directly with them.
Yeah, I think it's really challenging because I do worry about developing 500,000 different tools for 500 different thousand communities. And I think that I think, and this is a criticism, I've been engaged in this type of work. I think the field does this sometimes of like really doing, like we're going to do this co-design work with this particular community and build this particular tool. And I don't see that as a reasonable path forward. And I'm going to steal a term that one of my former trainees, Gio Ramos, who's now a faculty at UC Berkeley, uses of like good enough interventions, and that maybe we need like the good enough version that's going to work. And then we think about like what does that like last mile implementation look like? Like we're doing a project right now where we have sort of a peer support program that's trying to do that sort of last mile of tailoring. And I think sometimes it might need to be like the human engagement wrapper, which I don't think contradicts your point, Jonah. Like I think that piece really does need to be thoughtfully engaged with the community, but I do worry a little bit about this sort of just product proliferation I've seen as we think about sort of adaptation, and I just don't see that as a path forward. So I do think we need to make sure that we're engaging with communities early. We don't go to them late. We don't say like, hey, we have this thing for you now, please use it. But I do think we need to think about the complexity of how do we sort of think about a path forward that's going to make sense. And I'm not saying that there's a one size fits all. There is no one size fits all solution, but I think we also have to avoid the extreme of just building, a bunch of things for a bunch of different communities, because I just worry that that's not going to work. So I think it's balancing this tension of, respect and engagement with community with building out a system that doesn't sort of silo and proliferate all these different types of things.
Agreed with what was just said. I really appreciate Stephen bringing up the concept I've heard Gio talk about too of the good enough intervention. And I think it's really key that if we're thinking about good enough, that it's good enough for different groups in equivalent manners, rather than being designed for the majority and then being considered like, it's good enough for whatever minoritized groups are of interest there. One of the things that I've been excited about and interested in over the last couple of years has been Nick Titov out of MindSpot in Australia has been focusing a lot on the big five of meaningful activities, healthy thinking, goals and plans, the routines, social connections. And I've really appreciated the like taking a step back to what are the core, simple activities that we know can support mental health and wellness, and thinking about how we can best communicate both how people can get re-engaged with those or start doing those things again, and how to tailor that to different communities as well. I get nervous about here's the ideal intervention for this subgroup because it is so challenging to maintain and then get those things to the people in need, that I've been a lot more enthusiastic over recent years of how do we use what we know about psychological science to disseminate the right kinds of information and then make it be kind of engaging to folks to make changes in their life that are going to set them up on that pathway.
Yeah, also say, all this being said, we need to be policy advocates, because if we want these tools to reach folks who haven't got traditional services, we also have to realize broadband internet access isn't reaching them. Reimbursement aspects are often sort of focusing on those populations last as we think about these innovations. So we need sort of advocacy at multiple levels. Like, high-speed broadband is important. Regulation reimbursement is important. How do we actually get Medicaid and Medicare to pay for these things? So I think there's a lot we can talk about the design of the things themselves, but I think we also have to think about the design of the system to be able to support that. And someone's going to have to pay for it. And we don't want it to be those populations because that's just going to make it too slow to be able to get the products to them.
All right, good. Thank you. Another sort of set of questions here is around, how barriers to scaling, and we've been talking about this, but I think some of the questions are from the perspective of people who are either, developing companies or are thinking about developing companies. And I wonder if you have any thoughts from the perspective of of those people trying to go into this from the perspective of companies on the kinds of barriers that people should be thinking about. And then let me help a little bit, like one thought, because I think one of the things you talked about, Emily, was really, I think, particular that we don't think about in research as much, but really understanding value.
Yeah, this was something that I started doing a lot more thinking about actually back when I got to work with you at Northwestern of I had the bias sometimes as a psychologist and as a digital intervention developer that things like 2 extra minutes to introduce somebody to a tool was going to be no big deal. And then realizing as we were moving into trying to implement in clinics, like those 2 minutes add up throughout the day so many times. And I hadn't been aware of the frontline providers, how many other things they were already not able to fit into their encounters that they knew that they wanted to do and they like knew that they should be doing. And so taking a kind of a systems level approach to understanding what's happening at all points of where a tool will be introduced, where bought-in will be created, where buy-in will be created. Those are things that I think are really key, particularly in early service development and product development, because we can make a lot of assumptions when we're excited about something, so that we can move that direction.
Yeah, and I'm so glad that you bring that up because I know that's something we've talked a lot about, and I think that's true for companies. It's also true, I think, for people doing research that these things do not exist outside of the context through which they're delivered, and so developing a tool without understanding the delivery context is really setting you up for failure because then you've invested a lot of time, a lot of money, a lot of effort into creating something that then is going to have to be modified, and modifying things is not a simple modifying these kinds of tools is often not a simple or inexpensive process. So being very deliberate in upfront about the delivery context is really critical. Anything else from folks? So there's a few other questions about and I think you've touched on it a little bit, but maybe we can talk a little bit more about the use of these kinds of tools. Jonah mentioned it a little bit, but the use of these tools in the context of prevention and where are the gaps and the potential challenges in using these kinds of tools for prevention. And I think we've sort of touched on it in a few ways. I mean, Jonah touched on it in terms of using these tools earlier in the process for risk prevention. Stephen, you and others have kind of commented about thinking about this in terms of life transitions where there's vulnerabilities. But are there other ways, gaps or things that you can think about in terms of prevention?
Yeah, I mean, I think these tools have a huge opportunity to reach people upstream before they would sort of seek traditional services. And, I think we've seen some indication of that. Many of us have worked with Mental Health America. I think on their screening platform, we see some indication that people are really reaching out to that tool as like some of their first sort of knowledge of like what does mental health even mean. So I do think one thing we can think about is like not just reaching people through traditional healthcare settings, but can we actually get touch points like earlier in the process?
All right, and I realize now we are at the top of the hour, so I do want to just so I want to thank you all. This has been, I mean, for me, just a wonderful conversation, and I hope the audience has enjoyed it as much as I have. I do want to make one quick plug to folks to visit the exhibitors. There's a lot of interesting products out there, and I know I'm going to be going to spend some time with them, and I encourage everybody in the audience to as well.
Yeah, and I'll just say that the exhibitor booths are open throughout the whole conference, and tomorrow during lunch, Mind Science will be doing a demo. I will also say I don't think this was made explicit, but you might be wondering a little bit like, why are we doing a panel with, David Mohr's trainees? Why is David Mohr doing a keynote? I think we really do want to like just take a second and reflect. So David is transitioning from the president of SDMH to the past president. I am now the president of SDMH. But David's also transitioning in the sort of leadership role he's played at the Center for Behavioral Intervention Technologies at Northwestern, which really do count as like ground zero for digital mental health research here in the US. CBITS has been around for 15 plus years, and David has been leading that and doing excellent research, but also making such an impact on the field through the other folks that he's trained and helped move out into the field. And so I think many of us have I imagine everyone at this conference has read a David Mohr paper and taken something from it. But I just want to really shout out David's leadership in this, for CBITS, but also for the whole field of digital mental health. Like the field wouldn't be where it is without his leadership. And I think this is just a really fun opportunity to kind of reflect on that sort of component as we think about the past, present, and future.
Thank you so much. It's an honor. It's very kind of you, and it's an honor. And I have to say the greatest pleasure I've had over the years in my work has been working, with people like you. So thank you so much. It's brought me so much joy. So thank you, thank you, thank you.